Assalamu alaikum everyone. So today's high yield topic is diabetes in pregnancy. Now I want you to remember two main types. The first one being type 1 and type 2, that is a pre-existing diabetes, which means that the patient already has type 1 or type 2 diagnosed much before the pregnancy and is on treatment. The second type that I want you to remember, and today we are going to focus on that, is gestational diabetes mellitus, which means it was first diagnosed during pregnancy, which is routinely checked around 24 weeks of gestation. Now let us understand the risk factors and screening. Now, I want you to remember certain pointers for screening. The first one is at booking, we check for diabetes only when we have high-risk pregnancy. Second is a universal screening that is done for all other patients at 24 or 28 weeks of gestation. Now let us understand who are those high-risk people. The first one being someone who has a BMI of more than 30, previous macrosomic baby more than 4.5 kg, previous GDM, family history, specifically in the first degree relative and ethnic background. You may expect questions with ethnic background. If at any point the patient presents with glycosuria 2 positive at one occasion or 1 positive at 2 occasions, please check for GDM. Now let us understand the screening test and the diagnostic criteria. Screening test for gestational diabetes mellitus is done by OGTT, that is oral glucose tolerance test. Now let us understand the diagnostic criteria. Expect questions around this. So we are going to check both for fasting and postprandial. If fasting is more than 5.6 and 2-hour postprandial is more than 7.8, either value, if positive, confirms GDM. Management, we are going to focus on gestational diabetes first. Remember, GDM has a very stepwise approach, so we are going to go step by step. The first line for GDM management is always diet and exercise. You give a trial for 2 weeks and then recheck the patient. The second line is metformin. It is very safe to have in pregnancy. And the third line, you start insulin if the previous treatment fails or as addition. Meanwhile, please remember, if some patients do not tolerate metformin, you can start the patient on glibenclamide. And now let's understand insulin. You can start insulin at any point of time, even as first line, if the fasting blood sugar is more than 7 millimole per liter. Also, if the PBS is more than 7.5 millimole per liter, or the patient need pregnancy during any point of time with a preprandial glucose more than 6, and if the fetal abdominal circumference is more than 95th centile. Glibenclamide starts after 11 weeks. Now let us talk about the pre-existing diabetes, type 1 and type 2. Here I just want you to remember some key pointers from exam point of view, which might be helping you. Now first thing is, preconception HbA1c should be less than 6.1. If HbA1c is more than 10%, one should avoid pregnancy. Start the patient on 5 mg folic acid. Try 1 month before conception. Continue till 12-week gestation. Discontinue oral hypoglycemics, but you can keep metformin. It is very safe whenever required. Switch it to insulin. Have a dietitian review. And last but not the least, remember to stop AC inhibitors, A2A inhibitors and statins, and also no pregnancy if the patient has severe nephropathy. Now let us focus on the aim and the monitoring that is required during pregnancy. Remember, our aim during pregnancy is to achieve a fasting blood sugar of 5.3 millimole per liter or less than 7.8 millimole per liter post 1 hour after meal, or less than 6.4 millimole post 2 hours after meal. As far as the monitoring during pregnancy is concerned, we have some tool and we need to understand the goal. So let us go through the first monitoring target tool. The first one is capillary blood glucose. Check the CBG at least 4 to 6 times daily. Also check HbA1c each trimester if it is necessary. Do the ultrasound for fetal growth. Check it every 4 weeks from 28 weeks onwards. The bonus points are get an anomaly scan done at 18 to 20 weeks. Also get a growth scan at 28 weeks and check growth scan as well as the liquor volume at 28 weeks, 32 weeks and 36 weeks. Remember to check the renal function test during 16 weeks if it is required. Now, let us understand what should be our delivery planning. This is also one of the most high yield part. So remember, if the patient is on diet and the GDM is well controlled, induction should be planned around 38 to 40 weeks. If patient is requiring insulin, the induction should be planned at around 37 to 38 weeks. And if the patient has a pre-existing diabetes, often those patients are induced by 38 weeks. And if there is a history of macrosomia or poor control, consider early delivering the patient. For as far as C-section is concerned, if the patient estimated fetal weight is more than 4.5 kg, consider having a cesarean section to make sure to avoid shoulder dystocia. Regular monitoring for complication is necessary. Now let us understand complication. We are going to divide it into two. One is maternal complications and fetal or neonatal complications. It's a simple knowledge based. So maternal complication includes recurrent UTIs, preeclampsia, polyhydramnios, increased risk of C-section, and hypoglycemia during labor. These are the ones that you must remember. And now coming to the fetal and neonatal complications, remember macrosomia, shoulder dystocia, neonatal hypoglycemia, which is very important, respiratory distress syndrome, stillbirth. Remember, high supply of maternal glucose stimulates the pancreatic cells of the fetus, which causes more insulin release. However, after pregnancy or delivery, this glucose stops, but hyperinsulinemia state causes neonatal hypoglycemia. Postpartum management. Let us discuss this in brief. Remember, after delivery, the patient has to be checked on diabetes. If the patient has GDM, then it usually resolves. So you stop the medication just after delivery. Remember to check the patient after 6 to 12 weeks. Perform another OGTT test to make sure that the patient doesn't have type 2 diabetes mellitus, and also have a long-term follow-up, because once a patient has GDM, they have a chances to develop type 2 diabetes mellitus. One important point to remember is anyone with GDM should be pushed for breastfeeding, because it helps improve maternal glucose control. And check HbA1c in 12 weeks to investigate for T2DM. So dear friends, we have come to the quick summary table towards the end. So let us understand what we discussed and the pointers. Those are high yield for this topic. The first is the type. The patient may have pre-existing versus GDM. We have to do screening at booking. If we have high-risk patients, do it with OGTT test. And the for diagnosis, remember, fasting should be more than 5.6 or the 2-hour postprandial is more than 7.8. For management, there are 3-tier diet, metformin, insulin. You can start insulin if it is required. Delivery should be planned around 37 to 40 weeks. Depends upon the control and fetal weight. Complications, remember, macrosomia, preeclampsia, most importantly neonatal hypoglycemia, stillbirth, and postpartum. Get an OGTT and check HbA1c, continue breastfeeding, and rule out type 2 diabetes mellitus. So with this, we've come to the end in diabetes in pregnancy. Jazakumullahu khairan for watching. If you found this helpful, don't forget to like, share and subscribe for more high-yield emergency medicine MRCP revision topics. Stay safe and stay consistent in your learning.